slide deck. I know it's like 287 slides. Tons of pictures in this one. Tons of pictures, so don't get, again, wrapped around the axle on the number of slides. All right, and what do we got? We got all today, and then when's the exam? Next Friday? Next Thursday or whatever? Okay, so plenty of time. Plenty of time. All right? So let's talk about a little stupid biochemistry to start with, all right? You guys have talked I'm sure you've talked about, have you talked about the essential amino acids in biochemistry already? So you know that we're not going to list those where you have to memorize it. We're just going to, this is a very, very basic intro to biochemistry as it relates to the digestive system and absorption before we get into the actual anatomy and physiology of the system itself, okay? So basic stuff, you guys already know. 3 major macronutrients: proteins, lipids, and carbohydrates. All right, so micronutrients, so we get a monosaccharide, we can digest that. If we have a polysaccharide or a starch, we cannot unless it's broken down. You know that. Nothing that we're talking about that you don't already know. Micronutrients, vitamins, and minerals. Okay, so we have to have those in small quantities, right? Recommended daily allowance, you're familiar with that term, right? So most normal diets provide patients with as much of the micronutrients as necessary, the vitamins and minerals. Macronutrients necessary more for building blocks, for enzymatic reactions, for anabolism, building tissue, right? Carbohydrates and proteins, both 4 calories, but our lipids are our more nutrient and energy-rich source, and because they're delicious. So, right? Is that me? Okay, good. There we go. All right. Carbohydrates. Monosaccharides, disaccharides, polysaccharides. Okay, so from small to large, we can only absorb the monosaccharides like glucose or galactose. We have to digest everything else. So that's what we're going to talk about. Digestion of carbohydrates. We have enzymes, group of enzymes called amylases. All right. Salivary amylase is the primary one. Pancreatic amylase is the most significant one. All right. So starch digestion actually begins in the mouth when you're chewing food. You ever eaten some bread or some French fries and a little piece gets stuck in your teeth? By the time you get it out, it tastes a little sweet. That's because it started to break down. All right? Absorbable forms, these can come and go directly, right? So glucose, you guys know that not only from fruits, but we administer it iatrogenically if we need to raise somebody's blood sugar quickly, right? Because it can go directly into the bloodstream and begin to raise that glucose level. Everything else, as far as from the diet, disaccharides, polysaccharides, require digestion before we can absorb them. And then we have starches, which are our non-absorbable starches, like fiber, cellulose, things like that we take that are not absorbable, but they do serve a big purpose in digestion as far as helping move things along in the digestive system and bringing water into the lumen of the bowel, right? So if you have somebody who has constipation, we give them fiber, not just for the bulk that helps move everything along, but also for the water that it will draw into the lumen to help soften the stool, okay? Macronutrients, proteins, all right? Building blocks, these are what we need to make hormones that we've talked about, amino acid hormones, build muscle tissue, enzymatic reactions, so on and so forth, right? So, not to belabor this point, I know this stuff is fairly straightforward. Anything larger than a tripeptide cannot be absorbed, so that needs to be broken down. All right? Our peptid proteases, so proteases break down our proteins, and we'll talk about them. That's a large class of enzymes. Talk about where they come from. Protein digestion begins in earnest in the stomach. Okay? 20 essential amino acids, or 20 amino acids in total. 9 are essential, not 7 conditionally essential, meaning that we need them when we're under stress. And what do I mean by stress? Infection, physical stress, psychological stress, emotional stress. We need them at times of physiologic stress. So we need to take them in more. What does it mean when they're essential?
Can't make it.
It means we can't make it. We got to take them in exogenously. We have to eat them. We have to bring them in, right? And then there are 4 non-essential. Again, I think you guys have done this in biochemistry, so we don't need to go over the list. And it's a useless memorization exercise for anatomy and physiology. So we won't, okay? Just understand that 9 are essential, okay? Lipids, okay? You're going to see later on TAGs referred to triacylglycerols. It's the same thing as triglycerides. They're synonymous terms, okay? So if you see one, it's the same thing as triglycerides, okay? Triglycerides, most nutrient dense, right? 9 calories per gram. Excuse me, versus 4. Used for metabolism, also used to break down our fat-soluble vitamins so that we can absorb our fat-soluble vitamins, A, D, and K. All right? Vitamin A used for seeing. Okay. Vitamin D for skin and energy. Vitamin E for antioxidant properties, and vitamin K for coagulation cascade stuff. Okay, just briefly. Lipases will break down. All right, so you see the sort of amylases, proteases, lipases, right? So the ASE refers to an enzyme. Okay, so if you've never seen these before, that's an easy way to recognize it. If you're looking at the name of the actual enzyme, ASE will generally be something that will give it away. Okay. Most lipids are too large to be absorbed directly, so we have to break them down just like everything else, right? Our bile is a big contributor to the beginning of the earnest process of fat digestion, right? So bile is where? Where do we make bile?
Liver.
Liver. And where do we store and concentrate bile?
Gallbladder.
Gallbladder, right? We've already talked about something called cholecystokinin, right? When we eat a meal, cholecystokinin squeezes the gallbladder to help inject that bile into the biliary tree so that we can begin digestion. That's the beginning of the process of real fat digestion, okay? And then pancreatic lipase, which is a part of our pancreatic juice, which we're going to talk about in a few days, really helps break it down, and then along the way it's absorbed into the bloodstream, okay? Micelles. So this is the process, and we go off on this a little bit deeper into the fat process so that we can talk about lipoproteins, right? VLDL, LDL, HDL, and what they do, what they carry, what their responsibilities are, okay? So micelles is a monoglycerol and a fatty acid mixed with bile. That bile emulsifies, the process of emulsification. What is emulsification? Breaking down of fat. Rendering, right? Yep. Okay. Packaged together as triacylglycerol. So this is what I was saying. You could interchange this word here with triglycerides. Most people are probably more familiar with the term triglycerides, especially your patients will be. All right. Triacylglycerides packaged together with cholesterol, and they become chylomicrons, large, fatty molecules that can't go into the capillary system. All right. Because they're too large to go in the capillary system, where do you think they go? It says it on the slide, but what do you think? We talked about this already. A little bit in the circulation line. Anybody? Into the lymphatic system. Okay, into the lymphatic system. In the gut, in the GI tract. The lymphatic capillaries, like the entry portal to the lymphatic system is called a lacteal, L-A-C-T-E-A-L. Okay, right there at the bottom. That helps, that absorbs these larger chylomicrons, and that is sort of responsible for the way that lymph fluid looks in general. It's a fatty, yellowish type fluid, okay? And then, why does it all go into the thoracic duct? Anybody remember that slide? Because it's on the left side, right? So what dumps into the left side? All of this, right? So this goes on the right side, right? So again, this is, remember we talked about that lymph node, that Virchow's node, right? Okay. Huh? Trust your sign when you could feel it. Man, look at you guys. You're like, no shit. So, right? And it's because of the way it drains. It's because of the side of the body that it drains. Okay? So if you look at this, we have these fatty acids and monoglycerides. They're emulsified here by bile. The micelles make their way in. The triglycerides are packaged in the Golgi body with cholesterol. And then you have this big thing called these big things called chylomicrons, right? Too big to enter circulation, so they go directly into this lymphatic duct, which is called a lacteal. Okay? Looks like a complicated process, but it's really not. Okay? Does that make sense? Okay. And again, that's one of the functions of the lymphatic system, is to carry these particles back through circulation that are too large to be in the bloodstream. Okay? So chylomicrons, we just talked about that. When you have had a fatty meal, the level of chylomicrons in your bloodstream is going to be fairly large. So as fat's getting absorbed through the process that we'll talk about later, you can actually have turbid looking, like yellowish, fatty looking blood if you draw it after a high fat meal, within about an hour or so after a high fat meal. When you have more of a fasting state or more of a resting state, you don't have a lot of chylomicrons in the system, so your blood looks normal, red. Okay. So chylomicrons, we're going to go big to small here. So if we start chylomicrons, we're talking about the largest, and we're going all the way down to HDLs, which are the smallest. All right. And there's a little slide up here that helps with that. We've already talked about the chylomicrons. Now we have a very low density lipoprotein, high in triglycerides, okay, and delivery of triglycerides throughout the body is their main function of very low density lipoprotein, okay. LDLs are real bad guys, right? Everybody knows LDLs are no bueno. Why? Because of what they do. Transport cholesterol throughout the body, right? Now we need some cholesterol, because what does cholesterol do? Makes hormones, right? Exactly, right? But overabundance of cholesterol causes a whole host of cardiac type problems, right? So HDLs, now these, on the other hand, are good guys. High HDL is a good sign. It's actually a negative cardiac marker, a negative risk factor, I should say, protective factor. Right? And it's because they actually will bring cholesterol back into the hepatic system for recycling, right? So they sort of cannibalize cholesterol, if you want to think about it. They bring it back so it's used, so it's not sitting around outside somewhere else in the body, like in your arteries. Okay? So if you want to go from, again, largest over here to smallest over here, and then densities, right? Hopefully the name of the thing gives away the densities. Very low density, high density would give it away, but just in case, there you go, okay? Lipemic blood, right? So that's what it can actually look like. Fat meal, right? So, you know, you hit, anybody remember in the Chama Gaucha? Like a Brazilian steakhouse where you just sit there and eat so much meat until you fall asleep? That's what your blood looks like when it's over. Okay, all right. Okay, enough of that. Is that enough biochemistry for everybody? Good, me too. All right. Important though, especially the fat process, just important because it is a prelude to what the system does, to what we're going to be talking about. Okay. So, digestive system. What is it really? It's a food tube, right? Okay. It's a tube, and that, you know, when I used to teach GI, that's part of the problem, is that it is a tube, right? So when you have a hollow tube and you have a small neoplasm start to grow in it, what is the problem there? You have a circle this big that's used for passing stuff through. You have this tiny little thing growing in it. What's the problem? It doesn't show, it doesn't present overtly. You know what I mean? There's no overt symptoms to the tiniest little colonic polyp. There's no overt symptoms of the tiniest little neoplasm growing in your esophagus or in your small intestine. When does it become a problem? When it's really big. And what's the problem when it's already really big? It's in your lymphatic system and it's everywhere, right? Which, hence, why we go for screening of colon cancer and things like that, right? So we look for it early before it's a problem, before it presents as rectal bleeding or constipation or hematemesis or something like that, or maldigestion. Does that make sense, everybody? So again, think about that as you move forward. This hollow tube, before putting on your clinician hat, not just your anatomy and physiology student hat. You've got to look for these things early because they don't present overt. Make sense? All right. GI, okay, everybody, hopefully gastroenterology. We define those here in the freshman semester because I used to have seniors that didn't know the difference between nephrology and urology, and so we're talking about it here so that you guys understand our subspecialty referral. Gastroenterology, internal medicine subspecialties. Everybody understand the difference between medicine and surgery? Okay, somebody tell me. Not really. Nerds versus jocks, right? Calculators and scalpels. I mean, really, right? Like you can do invasive procedures in internal medicine clinic, right? Invasiveness is it? Would you say an EGD? And an EGD is an invasive procedure, right? We're talking surgical procedures. If I need something cut out, right? If I need a polyp or a piece of the colon taken out, that's not going to go to GI. That's going to go to general surgery or colorectal surgery in most cases. If I need an EGD or I need a colonoscopy, which are invasive procedures, then I'm going to go to GI because it's a medicine thing. Does that make sense? So close, but again, you guys understand what I'm saying? All right? If you need a surgery, you're going to send them to the surgeon. If you need a workup, you're going to send them. Most of the time, when do they make their way to the surgeon? After medicine's done with them, right? Or if medicine can't do anything else. Does that make sense to you? Okay. When you get to PE, and the nice thing about abdominal PE physical exam, they call it Clin skills now. I keep forgetting Clin skills. Have you started it? You haven't started abdominal yet, have you? Have you? Okay, good. The nice thing about abdominal PE physical exam is knowing the anatomy, knowing where everything is in the anatomy can help you understand the patient's chief complaint. If it hurts here, what are we thinking? Liver, gallbladder, right? If it hurts here, what are we thinking? Appendix, bowel, something, right? If it hurts over here, well, now pancreas, maybe spleen in a weird way. Down here, what are we thinking? Lower intestine, right? Descending colon, diverticulitis, constipation, who knows, right? Okay, that kind of stuff will help you. Now, unfortunately, if you throw ovaries and uterus into there, then all bets are off. It becomes a little bit more cloudy. But in general, if you understand where the anatomy is, you can understand the patient's chief complaint based on how it's likely to present. Okay? So, GI tract alimentary canal, in case you see that, you might see it sometimes referred to as the alimentary system. All right? But all parts from the opening of the tube to the other opening of the tube are included in the digestive system. So mouth and anus are part of the digestive system. Reason is because there's multiple types of digestion. What does the mouth start? Mechanical digestion and chemical digestion with salivary amylase. So again, don't lose that as a part of the GI tract, technically. Okay? Although I will say most cases of anything in the mouth, you're going to send either the dental or ENT. Still, understand that it has a role in this system that we're talking about today. So, just these are gee whiz facts. Do not spend brain power on this. It's just kind of neat, right? So it's in a state of constant contraction tonus, right? That tonus helps propel the food along in a process that we call peristalsis, all right? So when you have a cadaver, you lose that tonic musculature, and it actually gets longer. So there you go. All right. We will discuss that in a more practical matter here when we get to the large intestine, especially. All right. Digestive organs, accessory digestive organs. Again, ones you don't want to forget about. Not something, we don't typically think of the teeth as a digestive organ or the tongue as a digestive organ, but the teeth crush and chew the food. The tongue manipulates the food around into a bolus so that you can swallow and enter what we think of as a true digestive tract in the esophagus, right? Okay, salivary glands and ducts, don't forget about those, all right? And then again, does the liver participate in true digestion itself? Does the gallbladder or the pancreas? Do they participate in digestion or absorption? No, they do not, but they produce substances that are active, very active, of course, in digestion. So bile from the liver, right? And then all the pancreatic juice and enzymes that we're going to talk about when we get to pancreas are innately involved and responsible for most of the digestion that occurs, actually, right? So there's our accessory. Again, spleen really doesn't have much to do with digestion at all. It is in this lecture series only because it's an abdominal organ, but really the spleen is much more involved in hematopoiesis and lymphatic systems, okay? But just understand that. So, any questions so far? Straightforward so far, right? Yeah. Okay. Straightforward. I love this. 6 basis process ingestion. You got to stick stuff into the food hole to start the whole process going, okay? All right. And then secretion. The beginning of that, like the stimulus of the food entering your mouth, chewing, the secretion of salivary enzymes begins the process of other processes down the chain in preparation to receive that bolus. All right? So, GI system starts to churn a little bit. Stomach especially. It knows that it's about to receive some food. Got to start digestion. Need to be prepared for it. Right? We're going to talk about those processes, again, obviously much more in depth as we move along. Mixing and propulsion mostly due to the stomach, right? But again, think about accessory digestive organs. You put food in your mouth, you chew it up. That's the beginning of mixing. And then really the initial part of propulsion is the act of swallowing and moving it down. Your esophagus goes from skeletal voluntary muscle to smooth muscle. Then once you get to that smooth muscle, peristalsis takes over and it mixes its way all the way down through the rest of the chain, right? What is the main purpose of the stomach? Smash it up, right? And start digesting it so that when we get from a more solid food bolus, we have then kind that's moving through, a more liquid substance that's moving through the digestive process in the small and large intestine, right? Okay. Mechanical and chemical, I already referred to this. Mechanical digestion being the actual cutting, chewing, biting, mixing, smashing of the process versus chemical digestion, which is our enzymatic, our chemical molecular breakdown of these substances into absorbable forms. Okay? Absorption. The biggest portion, or the most important portion, right, is getting that absorption, absorbing the precious materials of all that we can extract from all of the food that we've eaten, and then eliminating the waste, the stuff that we don't need. And then ultimately defecation, right? We'll talk about that as well. Getting rid of solid material we don't need, eliminating it out. It's starting again, right? Questions about that? Nice and straightforward, right? All right, let's get into some actual anatomy. In general, these are the layers from outside to inside of the entire digestive tract. Again, it really is a tube, all right? And most of the tube has these properties. We'll highlight as we go through organ to organ to organ which ones are slightly different, but this in general is the setup, okay? So serosa, outside covering or adventitia, and then muscularis, muscular layer. What do you think's in the muscularis? The muscles, right? That are responsible for propulsion. Okay. Submucosa and mucosa. Mucosa being the innermost layer, right? The part that's in contact with GI contents. So as we go out and serosa, muscularis, submucosa, and mucosa. Okay? And we're going to go down these one by one now and sort of highlight the important structures within them. Not everything, but the things that are really important that you need to know about as a provider. Okay? So the serosa, also called the visceral peritoneum, so like the visceral surface, the outer surface of the organ. Okay? The adventitia, now this is the list of the places that have an adventitia versus a serosa. It's just slightly different. And one of the main purposes of the serosa and the adventitia and the peritoneal membrane, as we're going to talk about in a little while, is anchoring a lot of this stuff down, right? As you well know, your guts are fairly mobile, right? But not completely mobile. What would happen if you had no point of anchoring of your intestines, let's just say, your small intestine? It would just twist on itself and turn. That's called a volvulus, and that's bad. So we need to have a relative anchoring point for all these things so that they don't move around too much. We need some mobility. The stuff needs to be able to slide and turn on itself, but it cannot twist all the way around or just completely be free, or else we have a real problem. Okay? So, and actually, if you want to look at this, a lot of what this is retroperitoneal structures, and we'll talk about what that means in a sec too. So I put that word proximal in red because superior is true if you're talking about this being inferior, this being superior, but truthfully, proximal is the more accurate anatomic word, right? So the proximal portion of our esophagus is skeletal muscle, right? What does that mean? Why is that important? Voluntary, the act of swallowing, right? We have control over swallowing. Also, we have control over our gag reflex if it needs to go the other way, right? So the physical act, the initial part of swallowing is skeletal muscle. It's voluntary. It's under your control. Okay? Otherwise, if it wasn't, you just have to like put it back like a chicken and wait for it to fall down. You know what I mean? So as we go down, then more distal, meaning closer to the stomach, we switch now from skeletal to smooth muscle. And why is that important? Because I don't know about you, but I don't have time to physically move my food all the way through my gut. You know what I mean? So it does it itself, right? It goes from a physical portion where you have control over the swallowing, and then it takes over from there. All right? And then we don't pick up skeletal muscle until, again, where, you think? Famous, right? Yeah. Okay. So this is going to become repetitive to y'all because we're going to talk about the myenteric and submucosal plexi a lot. But myenteric plexus, okay, is in the muscularis. The easiest way to put that together, muscle and muscle, right? Muscularis has the myenteric plexus. So the prefix my, my, in medicine has to do with musculature in general, okay? What does the myenteric plexus do? I'll tell you in a little while. But in keeping with our very first class, we're back to having two names for everything. So the plexus of Auerbach, because apparently he discovered it. Okay. Any Black Keys fans in here? Maybe he was related to Dan Auerbach, who knows? Lead singer of the Black Keys. Submucosa. So we're going in, right? So we had serosa and adventitia, then we had muscularis, now we're at submucosa, okay? Mostly connective tissue here. Okay? And our submucosal plexus. That one's even easier. Submucosal plexus is in the submucosa. All right? Don't get, M for muscle confused with M for Meissner, right? So Meissner, plexus of Meissner, is the submucosal plexus. Going further in now, we had the lining of the GI tract, the mucosa. Right? Depending on where in the GI tract we are, we're going to have that lining containing various different types of cells, mostly to secrete protective mucus and other substances that protect it from the caustic substances. Because what is the stomach? It's a bag of acid, right? So that mucosa, that sensitive mucosa, has to be protected. We'll talk about the goblet cells that produce the mucus and the mucus that protects it and how that works. Same thing, even in the esophagus, we have to have that protective mucosa and certain types of specialized cells to prevent just sort of that abrasive removal of the top layer of cells because of the stuff that we eat, all right? And then as we go farther and farther, that stuff, it's mixed with acid. How do we buffer that? How do we protect the mucosa? So we're going to discuss the histology as we move along, okay? In the mucosa, we also have, so muscularis mucosa, outer layer of the mucosa. So these are sublayers, okay? Smooth muscle, so again, more propulsion. Lamina propria, this is a very important layer, which is the middle layer because of this stuff right here. Most of you probably don't, unless you have medical background, don't necessarily associate, most of your patients certainly will not associate the GI tract with lymphatics. It is a very active part of the lymphatic system, particularly because of this mucosal-associated lymphoid tissue. Now the problem with that is it can become cancerous. So there is something called MALT lymphoma that you'll learn about later. So cancer of the gut is not just limited to our typical colorectal cancers and things that we think about. There's also lymphomas that are very active in the gut as well, okay? And then the epithelium, the ultimate inside, what I was referring to as far as the different histologies of the cells that help protect the lining of the GI tract from the caustic substances that we put into it or that are injected into it via pancreatic enzymes, hydrochloric acid in the stomach, so on and so forth, okay? We also have exocrine and enteroendocrine cells, okay? Our exocrine cells, what does that mean? What does exocrine mean again? Directly into the lumen, right? Not into the bloodstream, into a duct, right? Exactly. So, perfect. And then, two different types. We're going to talk about these more later. I know they're highlighted here. But again, just different types of epithelium, right? Stratified squamous epithelium, that is exactly what it sounds like. Squamous epithelium that's stratified, so multiple layers to allow for the abrasion of the food to slough off some without penetrating into the more sensitive tissues, right? As it moves down, especially from the very, very distal portion of the esophagus into the stomach and further down, we go into this simple columnar epithelium, and those histologies change, again, based on the portion of the GI tract it is in and what job it needs to fulfill. I mentioned the goblet cells when you get into the stomach that secrete mucus to help protect it from that hydrochloric acid that it produces and so on. Okay? So, again, another picture. Told you, it's just more of the, it's going to be a lot of pictures, okay? Esophagus, stratified squamous epithelium, very flat, again. Stomach, much thicker epithelium, again. Why? Protection, just more protection. What do you think these little guys are in the small intestine? Villi and microvilli, right? Just like in the proximal convoluted tubule. It creates a brush border that helps increase area for absorption. And the large intestine really flattens back out. Not a whole lot of absorption happening in large intestine, a lot of water reabsorption happening there, but again, it's just, again, on message that as the cells change in the physical makeup, it's just based on the function of the organ that they're in, okay? Just like in the rest of the body. This is the only time we have some embryology, okay? And it's very, very basic, and the reason is because of the way that the GI tract is innervated. You guys have heard of splanchnic nerves at this point? You guys talk about them in A&P Ii? So what do they tell you about splanchnic nerves? Tell me.
They go straight to the synapse.
Yeah, so splanchnic nerves in this case are sympathetic innervations of the abdominal viscera, but the abdominal viscera don't have direct sensory organs. Like your actual organs don't hurt. Typically, they refer pain to another location. Okay, understanding as a clinician the pattern of that pain referral is key to helping form your differential diagnosis to what might actually be going on with this patient. All right. So back pain may not be back pain, although it might be. Mid-abdominal pain very well not. My belly button doesn't hurt, but something's referring my pain to there, right? Anybody's ever had a kidney stone? Kidneys refer their pain down to the testicles or the labia, right? So what masks as testicular pain may very well be a kidney stone. All right, so understanding sort of these patterns of referral helpful. And why do I bring up embryology? Not because I care about the actual development, but what ultimately develops and the nerves that they become innervate the midgut, the foregut, the hindgut, and then that branches off into the splanchnic innervation that we have as fully formed humans, okay? So, you don't, listen, look at me. Don't memorize this list, okay? Don't memorize this list. Just understand, very, very simply, if you were to try to memorize this list, which you will not, because I told you don't memorize this list, the foregut is the first portion, right? Salivary glands down to proximal duodenum. The midgut is the middle portion, and the hindgut is the end portion, okay? Take that for what it's worth, but you look at the innervation, right? The viscerosomatic conversions. Again, so what does viscerosomatic conversions kind of mean to you? I know it says it on the slide. Just give me something. What is this? Right? It means, like, again, we don't have a direct visceral innervation. We don't have sensory innervation of the viscera. Like, my pancreas doesn't hurt. You know what I mean? The area where my pancreas splanchnic nerves go to on my skin hurts, right? So understand that. Okay? So, greater splanchnic and lesser splanchnic and least splanchnic. So again, foregut, higher, middle, lower. All right? And this sort of pain pattern develops. Okay? So, gallbladder, liver pain oftentimes will refer to your shoulder. Okay? Kidney pain will refer again down here. Appendix luckily kind of stays where it's supposed to be. That is very fortunate. Anybody know what that spot is called? I know a lot of people know what that spot is called. McBurney's point, right? McBurney's point. Right between your umbilicus and your ASIS. Halfway between, that's McBurney's point. You push there, that's pretty pathognomonic for appendicitis. Okay? Heart pain. I know this heart's not an abdominal organ, but you see that referral pattern? What do we always talk about for heart attacks? Pain radiating down the jaw to the left arm, right? Okay? So again, important for recognition and formation of a differential diagnosis so you can broaden your differential. The key to making a differential diagnosis is making it broad enough to be inclusive, but not so broad that you don't know where to start. Okay? Easy enough so far? We're making good time, guys. We're going to be done early too, so there's no reason to overwhelm today. Everybody happy? Everybody good? All right. Let's talk about what these things actually do. The enteric nervous system, its entire, I mean, and it, you know, if you want to think about it as a separate entity, you can. Really, parasympathetic, sympathetic innervation, so it's autonomic nervous system, obviously. But which side of the autonomic nervous system do you think increases GI activity? Parasympathetic, the feed or breathe, the rest and digest side, right? And which side slows everything down? The sympathetic. You got it. We don't need blood going to our stomach when we're running away from the tiger. We need blood going to our stomach when we just ate the tiger. right? Got it? Okay. So, two plexi, we talked about these already. I told you this is going to get slightly repetitive. Neurons, interneurons, and sensory neurons. So neurons, interneurons connect the two plexi, and then sensory neurons are splanchnic nerves, sort of our visceral afferent nerves, or efferent nerves bring our stuff sensory back, okay? So, myenteric plexus causes GI tract motility. How convenient is that? Okay? Does that make sense? The myenteric plexus, the muscular plexi, is used for motility of the GI tract, peristalsis, and propulsion. Okay? Submucosal controls the secretions. Okay? So, easy memory trick. There it is. The only thing that throws it off is the eponymous names, Auerbach and Meissner, but you'll have to figure that one out on your own. Okay. But again, that should make sense. Where the plexi are, right? The muscularis layer controls repulsion. The submucosal layer is where a lot of the cells that create the secretions are in order to secrete them out into the lumen. Okay? Interneurons connect those two together, and then sensory neurons supply the epithelium. Sensory neurons, not necessarily as, pain, but stretch receptors or chemoreceptors. Similar to what we were seeing in the circulatory system, like stretch receptors to let us know, are we full? Have we reached a sense of satiety so that we can stop eating before we explode, right? Chemoreceptors, meaning, are we sensing chemical imbalance? We need something else to be made. What those things are, we will talk about later. But those are the kind of sensory receptors we're talking about, all right? Stretch receptors also useful to let you know when you have to have a bowel movement, right? So on and so forth. So, sympathetic nerves speed it up or slow down GI activity in the gut. Parasympathetic speed it up. It's a little visual representation of the next couple of slides. Vagus, their good old friend. You guys are talking about the vagus now, right? Okay. Excuse me. So, again, we know this already. Rest, digest, feed, breathe, whatever you want to call it. Stimulation, parasympathetic, increases our GI secretions, increases our GI motility, increases the processes of digestion and absorption, because that's what it does. All right? Sympathetic decreases. Do we got it? Got it. All right. All right, if you guys can stick with me through a couple of peritoneum slides, we can be done. All right? You guys can get an early lunch. You got to get up and go to the bathroom. Go ahead. Peritoneum. All right? First part of the actual organ systems we're going to be talking about. What's the serous membrane? Covering, something that makes serous fluid too. It produces a serous fluid to help covering. Helps move everything along. Okay? Makes sure everything's slippery. Doesn't get stuck. Okay? Parietal, if you think about anything that is parietal, it covers the wall. If you think about visceral, it covers the organ itself. So 2 layers of peritoneum, and then the peritoneal cavity is the space in between. Typically, that doesn't have a lot of fluid in it. Milliliters of fluid. We'll talk about a process here at the very end called ascites, where there is an overabundance of peritoneal fluid for one reason or another. And then what did I say about static fluid? It's bad. It becomes a swamp, especially in the gut. And then you can get something called bacterial peritonitis, which is bad. Okay? Retroperitoneal space, right, behind the physical peritoneum. It's important to understand which structures are retroperitoneal in nature. Kidneys are one we've already talked about, and small portions of the gut itself as it dives in and out around through its pathway along its track. Certain things are retroperitoneal. So ascending and descending. So where's our ascending colon? Ascending, transverse, descending, right? Ascending colon, descending colon are retroperitoneal, which means what? Transverse is intraperitoneal. Okay? Then as the sigmoid colon dives back forward a little bit, red proximal duodenum, so where's that? Right after the stomach, right? Kind of in this region right here. And then the pancreas, the head and the body of the pancreas are retroperitoneal, so like right here, sort of mid-epigastric. Okay? This is a physical representation again of what's in the peritoneum, what's retroperitoneal, in case the picture helps you out. But you can see the kidney here is the easiest one to stand out as being retroperitoneal in nature. Of course, this is your spine, so this is posterior. Okay? The peritoneum itself is a membrane, it's a series of membranes. And again, what is its major function besides covering and protection and making sure everything is slippery? Anchoring. All right, anchoring. These are points of anchoring that hold everything in relative place. There is significant mobility of the abdominal organs, but not enough to where they can fold on each other, because that would lead to, I mean, ultimately, what do you think is the risk of the bowel twisting on itself?
Pinch or blockage.
Okay, so that is the result. What is the real risk of the bowel folding on itself?
It would die.
Necrosis, cutting off the blood supply, right? There's blood vessels that go through that. If you twist it on itself, what happens? The blood vessels get pinched off. What happens to that piece of twisted bowel unless it's untwisted or reperfused? It dies, right? That's the real risk of volvulus, is perforation due to necrosis, okay? And then what do you have? Chemical peritonitis as the gut contents spill out into the peritoneum, right? Okay? So, 5 major folds: greater, omentum, falciform, lesser, and mesenteric mesocolon. Sounds like a lot. It's really a lot more easy to unpack as we go through it. You know, as you retire from the military active duty, you start to work on your greater omentum, right? Start to put some on, right? As you run less and less, you eat more and more. So I'm really working on my greater omentum here. It's where you would find the beer belly, okay? It drapes over the front. Like that's what you see as abdominal fat. There's subcutaneous fat, of course, too, but this is really what you see. This is what starts to add bulk as your patients become larger and larger, okay? So, attaches to the stomach and the duodenum, folds, and then attaches to the transverse colon, right? So there is a fold of that peritoneum, of that greater omentum. Okay? Lots of lymph tissue in these, but it's really just a large serous layer with fat in it, okay? Looking at this, the greater omentum, attached here to the underside of the stomach and the duodenum. And then you see this right here, you have this fold. And then again, attaches here to the transverse colon. And then again, that leaves the space in the middle being your peritoneal space, right? Okay. Falciform ligament is really not as fatty tissue as it is an anchoring ligament. It is, though, considered part of the peritoneum. So we have, I'm just going to show it to you, but this is the important thing. We have the ligament of teres, remnant of the umbilical vein. Where does the umbilical vein go? To your belly button, right, to the inside of the abdominal. So we have an actual point of anchorage, like a physical anchor to the abdominal wall of the liver, which is unique, right? So it is the most, if you want to say, immobile of the abdominal organs, the abdominal viscera, okay? Which is good because it shouldn't be moving around too much It's highly vascular. The portal system, the renal vein, the renal artery, we don't need that thing slipping and sliding around too much, okay? But looking here, this is the round ligament. This is that portion that it actually physically anchors it. And the falciform ligament is what really divides the liver into its left and right lobes. Those are the two main ones. There's others. There's an inferior diaphragmatic ligament, but it's not necessarily that we need that we talk about. Okay. Everybody follow me? Okay. Lesser omentum. Let me show it to you before I describe it here. The lesser omentum is just sort of this part, upper. Think of the upper portion of the stomach and the underside of the liver. Just again, anchoring. So we have the stomach anchored to the greater omentum and the lesser omentum, keeping it relatively in place so it doesn't slide around too much. If you go back to that, sorry, go back to this. It's just a fold that helps keep it in place. It does contain some very important structures, and we'll talk about these as we get closer or farther into it, into the hepatic and the hepatobiliary system. But again, the portal vein. What does the portal vein do? Do you guys remember? It brings nutrient-rich blood back from the small and large intestine back into the liver for processing and then movement. Processing, cleaning, some storage, and then movement back into the systemic circulation to be distributed out to the cells of the body that need the stuff. So what do we not need to happen to that portal vein? Right? Twisting of the stuff. So we get an anchoring. Okay? Make sense? Sort of? Not rocket surgery so far, right? Mesentery. I'll show you. I'm going to do the same thing. Mesentery. This is what helps keep this guy that we were talking about from twisting and turning all over itself. So again, yes, is the small intestine highly mobile? It sure is. But it has something holding it relatively in place so that it cannot, or should not, of course it can, it should not twist and turn on itself. So this part here within the small intestine is the mesentery, okay? Binds it to the posterior peritoneal wall, allows it to have mobility, but not too much, okay? And then going down, since this, we have the mesentery, that's to deal with the small intestine. And fortunately, the mesocolon, where do you think that's in? Having in mind, doing the relative same thing with the large intestine. What is it? Another name for the large intestine? The colon. Okay? So helping keep these straight. You have the greater omentum, stomach down, up to the transverse. You have the lesser omentum underneath the stomach to the liver, keeping it in place. You have the falciform ligament and the round ligament, those things that divide the liver and then attach the liver. Then you have the mesentery, which is small intestine, and the mesocolon, which is large intestine. So not that hard to keep straight. I know it's difficult, it's overwhelming the first time you hear it, but as you think about it, put it together in a chart or however you guys study, it's really not that hard to keep separate, okay? And again, there are two separate ones, pieces of the mesocolon, but grossly it's just what keeps there's a sigmoid and then there's the transverse, but ultimately what is it doing? It's keeping that colon, that basically is this large outline of the entire gut, anchored relatively in place. All right? And all of it, the tie that binds all of this peritoneum, blood vessels, lymphatics, immunologic tissue. So that's on every single one of these slides and see. So the sigmoid, what does sigmoid mean, everybody? S-shaped, right? So the S-shaped part of the colon as it comes down out, leaving the descending colon. So there's a sigmoid and there's a transverse. And then you see here these cuts right here. This is the mesentery dissected away, and here's a nice, helpful gentleman holding. holding the intestine. All right. All right. We got like 2 more and we're out. Okay. So ascites. Remember I said there's potential space here. It's a serous membrane. It's also a place for fluid to collect. One of the most common reasons for patients to develop ascites is portal hypertension, hypertension in the portal system because of hepatic disease. All right? To explain it simply, because we don't need to think about it right now, just so you know what I'm talking about. If the liver becomes non-compliant, high pressure area, that portal blood has a hard time returning into it because of scarring down for cirrhosis or hepatitis or whatever. What happens is you get a backflow. When you get a backflow or back pressure, what ultimately happens? Fluid third spaces. Remember we talking about the third space. And what's the third space? The interstitium, right? So we lose fluid into this potential space as it collects and accumulates, because the liver problem usually doesn't get better without intervention. We get this fluid collection, which we know as ascites. And you can see this is not abdominal fat, because if you look at the musculature of the patient's upper body, this is not a fat or obesity problem. This is a collection of fluid. You guys have done abdominal physical exam? Have you talked about fluid wave? Have you talked about shifting dullness? You guys haven't talked about those exams? All right, well, anyway, great. So you have a water here, right? Gravity, your friend. Where's the air? Up top, right? So you have fluid here. So you lay your patient down. Now where's the air? Up top, right? And then you shift them onto their side. Where's the air go? Bubble goes up this way, right? So you have like a high pitched sound here, tympani, because you have that air bubble there. You turn them here, and now you have that air bubble up here. So, okay, so the dullness as you're palpating their gut shifts, right? So the air bubble shifts up, the dullness shifts down. Shifting dullness test. That is a physical exam finding for ascites, right? Just using fluid dynamics as your friend. All right. Peritonitis, static fluid. What is it? One word, bad. Exactly. So if you have an infection or inflammation of the peritoneum, let me give you guys a hint for your surgical rotation. There's no such thing as an appendicitis sign. They're a peritoneal sign. They're very big on that, right? So what is this? What is this? That's McBurney's point, right? If there's McBurney's point, then what does that usually mean? Appendicitis, but they're peritoneal signs, right? So there's a sign of peritoneal inflammation and irritation, not necessarily of appendicitis, right? Because really, what is appendix doing? It's inflamed, it's irritated, but it's inflaming the peritoneum. So just understand that little stupid nonsense. You'll learn to get in surgery. But patients, we have ascites that becomes spontaneously infected. We have spontaneous bacterial peritonitis. Sometimes this occurs because of a surgical wound. Often this occurs because of an infection or some kind of penetration into the peritoneal cavity, right? So, you get that. It's kind of gross, right? This massive swelling in like this. See this color? That's never good. You never want like greenish yellow just running around your gut. Not on the outside, at least. Anyway, so peritonitis. All right, you want to do these now or tomorrow? Too bad. Huh? Do them now. So what's the biggest lipid? What's the biggest protein? Tripeptide. You guys got it? Yeah. Tripeptide. Okay. Which one delivers cholesterol? All right, cholesterol is no good. These guys are not our friends. LDL does most of the cholesterol delivery. Which one scavenges cholesterol? HDL. Very good. And which peritoneal fold houses the remnants of the umbilical vein? Yep. All right. Very good. That's all. Tomorrow we'll talk about this. That's 70 slides. That's pretty good, you guys. All right. Now, honestly, I know it seemed like we went a little fast today, but the beginning, the biochemistry stuff, I'm not saying it's not important, but it's pretty straightforward. The general, what does the digestive system do? It's also fairly straightforward. So is there anything that was unclear today? Any questions about anything? All right then, I will see you tomorrow. Yeah. So